I'm Robin Stevens. As we mentioned, I'm a recently appointed patient governor, and it's my pleasure to host this event. I must just state a conflict. I'm actually in the queue for a new knee, so I should be listening to the presentation from Andrew with extreme interest. So the topic for tonight for the Medicine for Members webinar is a regenerative therapy in orthopaedic surgery from steel to stem cells. And it's going to discuss the osteoarthritis condition, which causes pain and problems with joint function. We'll look at the early disease and treatments that aim to repair and regenerate the joint, and also highlight the importance of the new Cambridge Movement Surgical Hub in a ring-fenced planned care delivery on the site at Brooks, which I believe is opening later in the year. So we're pleased to be joined by Professor Andrew McCaskey, who is a CUH consultant and Professor of Orthopaedic Surgery and Head of the Department of Surgery at the University of Cambridge. His clinical interests is particular in lower limb, particularly hip disease in young adults, and his research is focused on cell and regenerative therapies related to bone and cartilage repair. He's also a director of the Versus Arthritis Tissue Engineering and Regenerative Therapy Centre, which brings together several UK institutions, and is a principal investigator at the Wellcome MRC Cambridge Stem Cell Institute and co-investigator in the UK RMP Hub for the engineered cell environment. In terms of the event, after this brief introduction, Andrew will speak for probably 35 or 40 minutes. You'll have the opportunity to ask questions. Please could you put your questions as they come to you in the chat box, and then at the end of the presentation, we'll do our best to answer as many of those as possible. If we can't answer them all this evening, we'll have your details and we'll be able to answer them afterwards. We'll do our best to do that. So at that point, it's my pleasure to hand over to Andrew, and I'm looking forward very much indeed to his presentation. Andrew, over to you.
Thank you. Can you hear me okay? Yeah. Well, many thanks for the invitation to talk this evening. And what I'm going to do is just share my screen. So if you just give me 1 minute. So can everyone see the slides okay?
Yeah.
Thank you. So as I said, well, many thanks for the opportunity to talk today. And we're going to talk, as you heard, about regenerative therapies in orthopedic surgery and kind of link them to steel and stem cells. And we'll talk more about that as we go along. So if I start, I'm going to say a few things about musculoskeletal disease. So the musculoskeletal system is bones, joints, muscles, and all the things that make them move. And in recent literature has highlighted how big a problem this is in the UK, with over 20 million people affected by this type of disease. And these types of conditions accounting for 1 in 7 of all GP consultations. And the kind of sums of money involved in care in a single year, you can see here at 5 billion. In amongst musculoskeletal disease, osteoarthritis is one of the big conditions. What does it look like? Well, here's a knee joint, and you can see that it has a lining in silver, which is cartilage. And in the disease, the cartilage is destroyed and the bone underneath comes to the fore, and the shape changes such that every type of movement of this joint becomes more painful and stiff, and then as a consequence, function is lost. How many people are affected? Well, this is an extremely common condition, as I've said. So over 8 million people will be affected by this condition. And let's start thinking about how we might treat this, particularly focusing initially on the end stage. And this is in relation to what you might call from steel. So end-stage arthritis is easily explained if you compare a hip joint. So this one on the left here has articular cartilage. It's nice and round, and there's a space between the ball and socket joint, in this case of a hip. Over on this side, you can see how the shape is lost, the cartilage has been removed, and the space is narrowed and obliterated in places. So in this situation, the joint is pretty well destroyed and becomes extremely painful to move. And that has that dysfunction. And for that kind of end-stage osteoarthritis, joint replacement has really emerged as a fantastic treatment. And this paper in 1961 in The Lancet, called Arthroplasty of the Hip, was written by Sir John Charnley. And it really laid the template for most joint replacements thereafter. And really, this is why I've used the word steel in the title, because as you can see, part of the components tend to be metal and parts of them, the socket side, tend to be softer things. And this original description was of what was called low friction arthroplasty, but that's just one type of hip replacement. And that really went on to be a fantastic procedure. In this paper, it's called the operation of the century because of the change in terms of pain relief and function restoration that came about after the procedure. As we have gone along in time, we can begin to see some limitations, particularly in this paper, the demand can increase, particularly when younger patients are being considered for this type of intervention. And again, here you can see the risk of revision. So if a patient has an operation, then it will last a certain amount of time, and sometimes it might work loose and need to be done a second time, and that's called revision. And you can see here that around 33% of patients require revision when their first operation is between the years of 50 and 55, but only 1 to 6% when over 70 years of age when they have their first operation. So this revision burden is important and is seen in younger patients. So when we look at our registries, we can see that joint replacement is an excellent procedure for end-stage disease. But the treatment options for earlier stages of the disease are much more limited. And really that's where I want to go next in trying to describe what that means and what we can do about it. So early osteoarthritis, going back to this diagram, is really affecting over 4 million people between the 45 to 64 years age group. So that's about half of our number. So that is still an awful lot of people, if you think about it, in the UK affected. So that represents an important area of unmet clinical need. So this group of patients have very little in the way of disease modifying and treatments in terms of surgery anyway. And really that's what I mean by unmet need. We then think about osteoarthritis at an early stage in a slightly different way and realize that it in fact goes through many stages. So here you can see some X-ray pictures that show the progression of the disease over time. And even on an X-ray, there can be at least 4 stages described in these X-ray pictures. And what you notice is that actually that was occurring over a very long period of time, those stages, with different opportunities all along the way when we might have been able to make an intervention. We now know also that there are really many types as well. So it's not just many stages, but many types. Sometimes the arthritis is driven by trauma, by a problem with cartilage or aging or metabolism or synovitis, that's the lining of the joint, or the bone around the joint. Our most recent understanding suggests that if you see the evolution of the disease over time, there was a point which can be called the window of opportunity when something happened, which is also something that could perhaps have been reversed. And you can see these triggers might include a genetic predisposition, a previous injury, obesity, malalignment, and lots of other risk factors. And at this time, you can see how we might have to rely on new ways of understanding the disease, whether that be biochemical or MRI, or before radiographic findings. So this preclinical phase, early stage OA, and then the established OA. So all of this is happening before where we start to treat at the moment, and could make a very big difference, and that's why it's called a window of opportunity. So if we think about end-stage disease here, there's been a long evolution of the disease before our intervention, which is extremely successful in the form of a joint replacement. But what we really want to do is have a much earlier intervention. In fact, it would probably be many interventions, and these would include non-surgical treatments like prevention, but also procedures that might include repair and regeneration, so that we can begin to repair and regenerate the joint and defer the need for operations like a joint replacement. So if we think about that early osteoarthritis treatments, then we start to think about cells. So regenerative medicine seeks to replace or regenerate human cells, tissues, or organs to restore or establish normal function. So trying to take something that's damaged and bring it back to normal function. Cell therapy, the use of actually giving a cell, is a platform technology available within that field of regenerative therapies. It's not the only way, but it's one key way you could go about that. So in this diagram, you can see a knee over here with a cartilage defect, and you can see two things highlighted. This one is called targeting, and what this is doing is a procedure that's actually working with the body's own cells. So not actually giving a cell, we're targeting the body's own cells. And it could be something as simple as this, which is microfracture or microdrilling, where within the cartilage defect, a communication is made into the bone marrow, and the bone marrow comes back into the defect and affects a type of repair. And that's called a marrow stimulation technique, and is relying on the cells that are already in the patient's bone marrow. Or we could think about giving a cell. And an example of that is autologous chondrocyte implantation. A chondrocyte is a cartilage cell, so giving a cartilage cell as an actual therapy. And you can see here in the defect this time, it's been filled with actual cartilage forming cells with a little roof to protect them. And that's called autologous chondrocyte implantation, or ACI, and it is an example of a treatment where you actually give a cell as the therapy. And in October 2017, a significant milestone was reached where that particular procedure of implantation of the cartilage cells was recommended by NICE for use in the NHS, because it was not just effective, but was cost effective. And this was important, obviously, for patients that might have a problem that could benefit with their knee, but also important for cell therapy beyond cartilage repair, because it starts to show that this kind of approach is useful. So existing regenerative approaches are demonstrating clinical utility. No single treatment, though, can re-establish the hyaline cartilage seen in normal articular cartilage as yet. So the limitations are in terms of quantity and quality, and often the cartilage that is produced is not the specialized one, but more of a fibrous structure called fibrocartilage. So what are the next steps? So the question might be, could stem cells help? I think to answer that question, we need to think a little more about stem cells. So here are some examples. So I'm going to talk first about embryonic cells. So within the developing embryo, there's a part of development called the blastocyst, where there is a group of cells in the inner cell wall. And you can see they can divide and form every single tissue that the adult human might require. So this is called pluripotency, and it's an astonishing biological property. They also have this ability to self-renew. A similar type of cell, in terms of what it can do in terms of self-renewal and pluripotency, can also be produced from adult cells. So this is called induced pluripotency, where the adult cell is induced to become pluripotent and have those properties, those ones of being able to produce every single type of cell in the body. And this was the subject of a Nobel Prize a few years ago, representing work by John Gurdon and Yamanaka. So the key to this then is self-renewal and pluripotency. But this type of cell, which is clearly a stem cell, is not expected in clinical use in the short term. So that's one important thing to bear in mind as we go forward, because there's another group of cells called mesenchymal stem cells. And a few years ago, they were described as the building blocks for molecular medicine in the 21st century. Why was that? Well, you can see here that there's a diagram showing one of these cells dividing, and it looks a bit like the ones that we saw for the other cells. But you can see that it's much less in terms of what it can do, and actually is limited to things like bone, cartilage, muscle, tendon, and so on. Now, this is called multipotency and is important, but it's much more limited than pluripotency. On the other hand, these cells are easily accessible in adult human patients who might come for treatment. Those patients might carry these cells around in their bone marrow or in their fat. So they're very easily accessible in the actual patient. And more than that, they're suitable for clinical use in the short term. So you could imagine there was a lot of excitement about how this might benefit patients, and this term mesenchymal stem cell was used. We now look a little bit more at how a cell might work. So there are two ways potentially. So like a stem cell, which you would think by the name would be the way it would work. And you can see here that what this means is that a cell like this, by differentiation, would actually become part of the target tissue. So the MSC abbreviation actually becomes, let's say, cartilage. It turns out that that is not really the favored mechanism. So like a stem cell, or the cells directly contributing to the new tissue, may not be what is happening, but rather this, which is behaving not like a stem cell. An indirect contribution to the new tissue, secreting signals to other cells, modulating immune responses, and an anti-inflammatory type effect. And you can see here those cells again. They're bringing about repair, but indirectly by affecting and working with lots of other cells in the body. This paper highlights the problem and need to change the name. So mesenchymal stem cells was that old term that was actually coined by Arnold Kaplan. And here he writes more recently in 2017, suggesting that we should actually change the name and not use the word stem cells for this sort of cell. Because unfortunately, the fact that MSCs are called stem cells is being used to infer that patients will receive direct medical benefit because they imagine that these cells will differentiate into the regenerating tissue producing cells. So here we have a summary that cell therapy has opportunities and challenges. We have resident targeting and cell therapies that I talked about. We have some interesting cell populations that on the one hand are multipotent, but actually on the other seem to have interactions with inflammation and the immune system. So the challenges then are that the ease of acquisition means that so-called mesenchymal stem cell therapies have actually reached the clinic. So what's needed now is a change and an increase in the following ways. To use appropriate names, for instance, to call things a stromal cell would be a step in the right direction rather than to use the word stem. We also need mechanistic insight into understanding how the cells might work, evidence of clinical effect before widespread adoption, and the requirement, therefore, for well-structured translational research. So as we go to develop new treatments, it's that translational research that becomes very important. So here you can see a diagram that shows effectively a bench, a laboratory over here, and the bedside over here. Obviously it's surgery, so we put a flask and a knife, but you can see it's not just bench to bedside. The arrows are showing that this is a continuous process. And how can that work? Well, by thinking of samples, imaging, the laboratory and the clinical trials, we can create a process that moves in both directions. And in scientific terms, this will now include things like molecular biology, so these advanced ways of understanding the way cells work, brand new types of imaging that can help us understand the type of disease and stage that we're looking at, preclinical pathways which are taking laboratory findings towards the patient, and then the clinical trials that measure whether something is actually working in clinical practice and is effective. Just to give you an idea of a little bit of what that can look like. So we can use DNA, RNA, and protein to advance our understanding of the disease at a molecular level. And here you can see that samples taken from a knee joint at the time of joint replacement show that we can derive DNA, RNA, and protein. And then that helps us understand the molecular profiles of the tissue, develop markers of cartilage degeneration, which helps us understand earlier studies that were relating to the genome, the GWAS signals, and potentially the use and development of new drugs or drug repurposing. In terms of advances in imaging, we're now able to look in 3D personalized cartilage maps. And you can see here how an MRI is segmented and a cartilage map is developed for that patient. And we're now able, this is work we're doing here, all of this work is work that we're part of, is able to create that and understand disease progression in a matter of 6 months, which is really very important in terms of understanding whether a new therapy might work. And if you think about x-rays, how that was actually happening over many years, to be able to understand change in a few months is really a very useful step forward. It's not all about giving cells, it's also about targeting cells. And you can see here a molecule called agrin. And here we've been able to show that it can improve cartilage repair. And that kind of molecule is being developed more towards the clinic as a therapeutic option. And then the final step in the jigsaw, that clinical trial work. Here's just one example relating to osteoarthritis. Lipoaspiration is taking a small amount of fat away from the body, deriving some cells, growing them in the laboratory, bringing them back as a joint injection. And this whole study was a phase 2B multicenter study. But you can see this was pan-European, phase 2B, prospective, multicenter, double-blind, triple-armed, randomized versus a placebo. So this is a lot of detail, and it needs that detail to arrive at the correct level of evidence. And evidence makes a big difference to what we do, whether it's laboratory evidence or clinical trial evidence. And you can see here how the level of evidence builds up an understanding of whether something is going to be effective. And this is just going back to the importance of that name. The word stem cell, to many people, implies that kind of extra biological property that maybe some of the cells, as I've discussed, aren't using as part of their effect. And you can see we need to manage expectations. So this is from a Radio 4 article, The Stem Cell Hard Cell, which is an interesting one if you want to listen to that. So managing expectation, developing a right understanding of mechanism and effect is very important. And this brings us to a stratified approach where we end up now. If we think of all the people with osteoarthritis, we can now see them as separated groups because we understand many stages, many types. And that allows us to develop our stratification tools, which can involve that molecular biology I was talking about or advanced imaging. This means that we can sort out from the bigger group of osteoarthritis subsets of stratified patients. that can then be given a targeted treatment more suited to the particular characteristics of that subset. And that's called stratified medicine. And it means the right patient gets the right treatment at the right time. And if you're doing clinical trials, obviously it will make comparisons much better to use this kind of approach. It's also part of a stepwise approach. So here, this time with knees, you can see the progression of radiographs over the 4 stages I showed earlier. And obviously at this point, this is advanced disease where we know our joint replacement is an extremely good option. But we would like to go back in the disease to earlier time points. And there we see treatments might include molecule to materials, cell therapy with minimally invasive surgery like arthroscopy, and then constructs like osteochondral strategies, which may be using biomaterials. The next part of this is optimizing how we can take that forward and deliver these treatments. At the beginning of the talk, you may have seen mention of the Tissue Engineering Center, and this just shows what that kind of means. It's an example of some of our research capability. So that's led from Cambridge, but actually is a consortium involving lots of universities, Newcastle, Aberdeen, York, Keele, and Oswestry, and Birmingham. And that means that the different facilities on each site, whether that be clinical research facilities, the Stem Cell Institute, the ability to bioprint and grow cells, to perform understanding in the laboratory, further understanding in the laboratory, including all sorts of new techniques in molecular biology, to giving cells, and then including our biomaterials. This whole group of interdisciplinary people and places of work brings an incredible research capability, and this is replicated also across Cambridge and the different parts of the university. So that means we can start to build on that capability, and if you do that, you start to think of the musculoskeletal system in a slightly different way. So here in this diagram, you can see we can think of it in terms of health and disease. So one thing that's absolutely critical to both of these things is movement. So movement is key to healthy living, and the loss of movement or painful movement is a key part of musculoskeletal disease. So that word is really important at understanding the tipping point between health and disease of the musculoskeletal system. So a few years ago, we started to develop an idea of a research hospital vision along those lines, the movement center. And what that meant was it had a mission which was in musculoskeletal health to prevent disease and enhance quality of life. And in musculoskeletal disease, to restore movement and relieve pain. And to have excellence in 2 things: the delivery of treatments that we know about today and the development of treatments for the future. And in this vision, you can see that this space would have lots of different components. So the delivery being that kind of hospital component that we're very familiar with, but also in the same space, it's research, innovation, education, engagement and outreach with patient and public in terms of engagement and involvement, and a collaborative pull-through. That's with different partners, whether they be in the university, other universities, or industry working in the same field. You can then see movement in a much wider context and how it becomes a global challenge. We now know that regular physical activity, that's healthy movement, is proven to help prevent diseases, not musculoskeletal ones, actually other diseases like heart disease, stroke, diabetes, breast and colon cancer. Activity helps to prevent hypertension and obesity and can improve mental health, quality of life, and well-being. These are the statistics that 1 in 4 adults do not currently meet the global recommendations for physical activity. But perhaps even more importantly, 3 in 4 adolescents do not currently meet the global recommendations for physical activity. So you can see, if this is very important, which it is, that it becomes even more pressing to try and think how we can extend this message. And this globally is costing a lot of money. It's also part of a precision health approach. So if you remember back at the beginning, we talked about this window of opportunity early in the disease, before the disease progresses. And precision health is something that looks at early interventions that could be made to avoid an individual progressing to a specific clinical condition, in our case, let's say osteoarthritis, or to significantly mitigate or delay the onset of the condition. And this can involve lots of different modalities and treatments. And I explained already how non-surgical and surgical could be brought together. You can see here activity into rehabilitation and physiotherapy, interacting with our new techniques that will help us understand the disease stage, which could include the molecular kind of techniques that I described, or new imaging, can all be seen now ahead of some of the procedures that we were talking about. So obviously that was a research hospital vision. What we have at the moment, nearing completion, is Cambridge Movement Surgical Hub, which is one of those first steps on the road to that sort of goal. So the Movement Surgical Hub is a surgical hub, which is really part of the GIRFT, or Getting It Right First Time agenda, which is a national program where hubs will deliver capacity to address the elective backlog and establish new connected ways of working. They're characteristically, or can be, ring-fenced, either separate to a building or within a building. But this means that they are protected beds, meaning that they're resistant to cancellations, and that would improve efficiency. They're described, many of the pathways, as high volume, low complexity, which means they're particularly designed to deliver safely volumes of surgery that can address and achieve these types of problems. And in our case, we've created a space of around 40 beds and 3 theatres. And as I've said already, in terms of these pathways, it's pathway driven. So this is an example of a pathway, and you can see how over the last 2 or 3 years, people have developed an understanding of all of the stages of care and tried to itemize how those pathways can work. And what that does is allow all stakeholders to work in a more efficient way in this type of environment. And a surgical hub is optimized to this kind of surgery. It doesn't just apply to orthopedics, there are other types of surgery where this approach is being rolled out nationally. In our own case, though, in addition to deliver capacity, we also want, obviously, to address the backlog, but we also have these other aspirations, which is where we understand current treatments to drive innovation of those. And obviously, from what I've said before, you can see we would also have the ambition to develop new treatments. And here you can see a slide of the progress. It's situated about there on the biocampus, and if you're driving, you'll probably see it on the campus in a much more finished kind of form on the outside anyway. So this is a really important and exciting first step on the realization of some of the goals I discussed earlier. And in particular, it helps patients on the waiting list in terms of delivering capacity and addressing the backlog, but allowing us to do those additional things that we wanted in our vision. So I just try and bring things back as a summary now. Osteoarthritis is an important condition. If we think about the steel part of what we talked about, joint replacement is an excellent operation for end-stage disease. But osteoarthritis is an important clinical condition with unmet need, an opportunity to develop new treatments. Thinking about the stem cell part, the term mesenchymal stem cell can lead to confusion in terms of mechanism and expectation, and that's been widely reported. And I showed you one or two examples of that. Regenerative therapies and cell therapies, whether they be targeting the body's own cells or actually giving a cell, are important therapeutic approaches. And one of them I've highlighted, that's the cartilage cell therapy, has already gained nice approval for use in the National Health Service. So looking ahead, gathering of evidence is very important, and this involves translational research, and I showed examples of that. In this way, a range of evidence-based treatment options prior to joint replacement will emerge, and they will be both surgical and non-surgical. So to conclude, we have a wider vision relating to movement, which relates to excellence in both the delivery of a treatment today and the development of new treatments for the future. And the Cambridge Movement Surgical Hub is really an excellent part of that delivering for patients, because it makes a huge difference to the many hundreds of patients waiting for planned orthopedic surgery, many living in pain and struggling to stay active. In addition, it will help those with bone and joint disease more broadly and at earlier stages through research and innovation into current treatment, delivery, and future treatments. So I'll bring this to a close and say thank you for listening and acknowledge some people. You can imagine this is absolutely nothing to do with one person's work. It's to do with lots and lots of people working together. And this is just the tip of the iceberg, the more senior people working together, and there'll be many other types of researcher working with them.
Andrew, thank you. Thank you very much indeed. That was as clear as it could be to a layman. So thank you on timing too. I think you did fantastically well to get through all those slides in perfect timing. I think you must have done this before. So thank you. We've got some questions on the chat box. Maybe a couple of might be questions that are probably might be better taken offline because they're detailed and specific. So any questions that we don't cover on the call, we will cover afterwards, but it might be easier to deal with some separately, but some on the call. The first one comes asks where do steroid injections fit into this? And if I could just extend that to also include, I think there's a treatment involving the injection of synthetic synovial fluid or HCAs. Okay, that's a layman's comment, but I wondered how those treatments fit into the process that you've just described.
So I think there's a longer talk that can focus in on lots of different specifics, but injectables that's a nice way of thinking about one of the simpler versions of treatment. So an injection into a joint. And in fact, one of those therapies in the clinical trial there, the cells come back as an injection to go into the knee with arthritis in it. So on the one hand, an injectable could even be something like a cell therapy injected into the joint. And that's obviously a clinical trial, so that's for the future. At the other end of things, we have steroid injections, which have been around for a long time. And obviously what they can do is help with any inflammation in a joint, which can therefore bring about a reduction in pain and perhaps an increase in function. That can be a sort of a therapeutic kind of a thing, or it can also be very useful as locating the source of pain and confirming where a pain's coming from. That's more diagnostic. And in between those kind of two, the cell therapy to the steroid, there are different types of injection that have become available. So some of those might include hyaluronic acid, which is that sort of molecule that is part of the actual cartilage structure itself. And that would be part of that armory. And then there are another group of injections which might be seen under the idea of what we call orthobiologics, which is biologically active, naturally occurring injectables. And we wrote a lot of papers a couple of years ago and helped create some guidance for the British Orthopaedic Association about those therapies. Again, the key to understanding these is to understand how they work. So it's that mechanism, and then how effective they are. So trying to understand whether there is evidence that they're effective. And each year that goes by, the clinical trials will get better at showing us both those things. So based on the mechanism, whether they become clinically effective. So injectables is one of the in terms of administration of some of these things, is one of the key ways to do it, and obviously avoids a bigger procedure. Bigger procedures offer other things in terms of access, so that takes us on to another type of therapy thereafter.
Would it be fair to say that perhaps the injection of steroids and HCAs maybe come towards the end of the process when you're maybe getting close to surgery, but you're just trying to minimize the symptoms until such time as you can have the surgery? Would that be a fair comment? Or
well, sometimes there's a middle ground or an earlier time point. But as I said, firstly, trying to understand where a pain comes from. Is it from inside a joint or somewhere near the joint? So an intra-articular injection can sometimes help with that. So that's the diagnostic part. In terms of therapeutically helping the pain, then that can be at different time points. And maybe ahead of a joint replacement is where generally that would be, obviously. Yeah.
Okay, thank you. You've talked obviously that the presentation is based on osteoarthritis. Does it have the same relevance or partly for rheumatoid arthritis damage as well, or not?
The group of conditions that we might call collectively inflammatory arthritis, where rheumatoid arthritis might be one of those. So that's a group of conditions treated by rheumatologists. So numerically, it's much less common, and it's a kind of slightly different disease where the body's own immune system is driving the process. For that group of conditions, there's a very specific kind of disease-modifying molecule treatments that have become available over the last few years, and they've really brought about fantastic change in the treatment of those conditions compared to how it was, let's say, 20 years ago. So there, the unmet need was slightly different, and the mechanism is slightly different, and there now are sort of pharmaceutical drugs that are very effective by understanding that mechanism and can control that particular disease very well. And you can see that in that there's a different disease though. So I think in terms of numbers, the thing is that osteoarthritis is such a big problem, and perhaps because it has joint replacement as the end stage treatment, has a great treatment at the end, but that means what do we do before that? One of my colleagues actually in Oswestry used to describe this. If you think about a renal transplant or a heart transplant, a bit like a replacement joint. What do you do before that? Well, we're very aware of how we might give and develop different treatments for the treatment of heart disease before the heart transplant, or renal disease, understanding and treating different types and forms of renal disease before the renal transplant. But in joint replacement, we haven't had that kind of opportunity to develop treatments before the joint replacement. And that's the space that we're trying to work in right now, to create different types of treatment all ahead of a joint replacement, so that the whole timeline where you can have a good treatment is extended, because of that problem that ultimately a joint replacement may loosen over time and need to be done again. So if we push that down the road in terms of time, so that it's further away, and bring in these new treatments at an earlier stage, whether they be surgical or non-surgical, sequentially, they will offer a good kind of pathway or roadmap of treatments all ahead of the joint replacement.
Thanks, Andrew. There's a question here that actually plays, I think, quite well to the movement hub plan. Obviously, in terms of being fitter and trying to reduce the incidence of this process. Anyway, question is: Are there any plans to include prehab prior to effective surgery to optimize outcomes? And linked to that, wouldn't doing surgery before the very end stage would also so also not so sorry, I'll try me that again. Would doing surgery before the very end stage, but also not too early to need a revision of better outcomes? We seem to do surgery very late here compared to other countries.
Yeah. Okay. So there are two different sorts of questions. So
Yeah.
rehabilitation, the physical therapy to build up the musculoskeletal system is a really important treatment for most conditions. And obviously, time before an intervention can be a very important part of getting a.
Andrew, you might need to turn off your picture. I think you're breaking up slightly.
I think I'm plugged in. Can you hear me, Namu?
Yeah, I can hear you fine. I wonder if it's on Stephen's end.
I think it might be on the other end. Can everyone? Oh, can't tell.
Yeah,
But
I think
you can
it's
hear me, right?
Robin's, and yeah, it's all good on mine.
Carry on. I'll turn off my picture in that case.
Where was I up to? Oh. We've lost Robin.
No, I'm still here.
No, I think he's just switched his computer.
Could you just repeat the question, Robin? The first one for me.
Yeah, I just need to find it again.
Thanks.
I've got it here, Robin, if that's helpful.
Yeah, okay.
Yeah. Are there any plans to include prehab?
Yeah.
This is not just education prior to elective surgery to optimize outcomes.
Yes. So I think, as I said, rehabilitation in the form of physical therapies, for example, is really important in most musculoskeletal disease treatment, and I've positioned that. And certainly before a procedure, if there is scope to develop that, it's called prehabilitation, and we hope that ultimately makes the recovery and the outcome better. And there are specific research, there is specific research into that going on here in research groups in Cambridge about that. So that's very important. Then the next one was about.
The next one was we didn't doing surgery before the very end stage, but also not too early to need revision, have better outcomes. We seem to do surgery very late here compared to other countries.
Well, that's quite a complicated question, but I think I indicated a sort of target age group and the risk of revision. And that's a very important way of looking at it. So if you have your index procedure between 50 and 55, which is a relatively young age group, then 33% of patients will require a revision. And obviously at that later time point of, let's say, 70, when you have your first operation, it's only between 1% and 6%. So that's showing you that the risk of another procedure is real as you move into those younger age groups. Obviously, we don't have that selection of newer treatments at this point, but as we do, this is the sort of area where it would be good to bring in those treatments. That's the area of unmet need ultimately, so that we can keep our fantastic operation with the joint replacement to a little bit later, if possible, by deferring it. We still need effective treatments in terms of pain relief and restoration of function. So that is a given with the new treatments, but how you go about that may vary with this new type of approach.
Great, thank you. We have another one question saying, what treatments are currently available to address the unmet need of early arthritis, and how can these be accessed?
So, well, this is about the research that we do. So the one that is available as a cell therapy is autologous chondrocyte implantation. And that was that diagram I showed where a cell actually becomes part of the therapy and can go into what's called a cartilage defect. So that's an early type of damage in the cartilage in the form of let's say a circle. I showed it in that diagram that can then be filled with the cells. So that type of procedure is available within the NHS, and the hub will hope to do that procedure shortly after opening within the first few months. We're one of the few centres that are able to do that nationally, and we will bring that particular treatment forward. Then the next ones will require what I was talking about before, understanding of mechanism, but that is partly done. So it's more about the clinical trials to establish effectiveness. So shortly after, we would hope over the next 1 to 2 years to develop clinical trials based on some of those other types of therapy. Key to this, and we haven't really talked about this today, is the manufacturing. So the ability to make a cell product on site. And we're very fortunate here to have fantastic facilities in one of the buildings called the Jeffrey Cheer building, where cells can be taken from a patient and then grown up in what's called a GMP environment so that they're clinical grade, so that they can be given back to a patient. So that's a fantastic facility which will greatly help us bring cell therapy to patients who are receiving their treatment in places like the hub. Obviously, this isn't just for musculoskeletal disease, but for other diseases, but particularly will be helpful for us in that regard.
Indeed, thank you. There's also one here that talks that sort of moves us into polymyalgia, and I have pain in my feet, joint, hips, and shoulder and neck that is very painful and is attributed to my long-term polymyalgia. I wondered whether or not it's all due to that, and whether the future treatments might help my pain and effective autoimmune systems.
So this goes back to what I was talking about before. The group of conditions that are more generalized, less obviously structural, that might be due to some other kind of more generalized process. We were talking about inflammatory disease before, are mainly seen by my rheumatological colleagues and constitute a slightly different approach. And in some cases, there are those disease-modifying medications that I was talking about. Cell therapy has been described, not the ones that I've talked about, but there are types of cell therapy that are in development for some of these. But we'll have to see as we move along. So not in the very, very short term, but certainly some conditions where the immune system is involved, the inflammatory type of problem, have been identified in terms of some of this type of treatment. But the principal target is osteoarthritis and cartilage repair. That's principally where we're trying to bring about change because of the huge number of people affected, obviously. As I was indicating at the beginning.
Yeah. Another question. I have early stage osteoarthritis in one knee. How do I offer to take part in one of your research projects, if that's possible?
Yes, so when they're open, we will be able to show them. So we had one that was around and then that's closed now. And then as they come, they will be open and they'll be seen on the national kind of open clinical trials registers. But hopefully we can also communicate maybe through this forum when we have those sort of things. If people are interested in this, then maybe we can use local types of systems, even like the member network might be a very useful way of helping people understand that.
Okay, thank you. Another one just arrived. One of my knees is on an extremely long waiting list for a complete replacement. The other is fine at present, but showing signs of going the same way, which is also helpful if feet go the same way, I suppose. Would the new research negate replacement in the second knee eventually? One hip was replaced 15 years ago and is still functioning perfectly.
I think that's getting too specific.
Okay, fair enough.
If that's all right. Sorry, I wouldn't want to say something that.
No, indeed. I think you'll say that some of these questions are we better.
No. I mean, a few years ago, I gave a lecture for ACT, and the interest was at the end because it was face to face. You could have different types of conversation. But it's. I think I wouldn't want to say too much if it's like this and not give the right sort of information over.
No, indeed. There's another question which it's probably not. It's a little bit specific, but I'll cover it because obviously it's something which shows the requirement, I guess, for further options. I've been on steroids for 16 years with many side effects, so would welcome any new treatments other than orals. I guess
yes.
It's rather than a question. But...
Yes. Well, I think that's the whole motivation of what we're doing.
Indeed.
Is to, we've got joint replacement on one end, let's say, and although it's not always for the same condition, let's say we've got our injections at the other end, and we're trying to fill that space. And you know, some of this is in the clinic, some of this is about to come in as clinical trials. So this isn't 5 to 10 years. Some of this is of the now, but it will become even more as the next few years go along.
Yeah. Another one, and I guess this is you're working this out as you go along, and it's probably a case by case basis. But is there an age and also a stage of damage before which stem cell treatment is optimized? I guess by definition, a point at which it probably isn't going to work, or it's too early to tell. But
so this is one of the slides I showed was the window of opportunity slide.
Yeah.
And it had the sort of X-ray way of looking at life. And obviously I showed you the 4 stages that have been described over the years.
Mm.
And that helps us understand and break down patients into 4 stages. So it's a useful stratification up to a point, but it's not so good at this sort of thing, which is trying to break down those subgroups even further. So the way we were going to do that and are doing that and have developed methods to do that is about that. Firstly, the advanced imaging. So that's things like the cartilage mapping that I showed you. Yeah. And there will be other modalities that will help in that regard also. And then alongside understanding what's happening in the disease at a tissue level, and that's the advanced molecular biology kind of approach, will also unlock some of the staging. And we will add more and more parameters to that, sometimes as patient-reported outcomes and other measurements that we'll do. So gradually we'll build a toolkit or toolbox, if you like, of platform technologies that will take us to a new level of stratification beyond those 4 stages of the X-ray. We have some of the tools already, and we'll begin to use them with patient groups in the coming years. So it's a really important question because that stratification is really important. We also know, though, that actually things stratify out in different subgroups. So mechanical alignment is very important. So if we detect that, thinking about, let's say, a regenerative therapy on its own wouldn't be useful. We need to think about the other aspects of that. So that would be multimodal, where you think about the correction of a mechanical problem, for example, along with the possibility of an advanced therapy like we've been talking about. And the two together then kind of making the new system of treatment.
I think we just got time just for probably just 2 questions, and the second one I was going to cover anyway is obviously in terms of the cost, the estimated cost of this and the NICE report. Is this something which you see as being this treatment being generally available on the NHS over the next 2 or 3 years, or is it going to be quite a struggle to get this? Because obviously it's new. It's something which obviously in the past perhaps will be private, but it's something you think will be perhaps not readily available, but certainly available in certain cases through the NHS as the process.
So yes, I think the chondrocyte therapy, certainly the NICE guidance was that it was cost effective, meaning that the cost for the NHS was appropriate because of the benefit that the patients have, particularly at that younger age, I guess. So that is available. It's not for everybody, though. It's for a very precise cohort. So part of this will be to take that kind of good work and see how much we can adapt it to the next group and the next group, and prove and show that it's still clinically effective in that other subgroup, and expand the philosophy. But that hopefully is definitely the goal of an NHS treatment. That's what we're working towards. And the manufacture of cells that I was talking about will be in the NHS. It kind of builds on the sorts of manufacturing and cell handling that you might see in bone marrow transplant, for instance, in hematology. It's not exactly the same, but that sort of expertise and that place in the hospital is great and ideal for doing this.
Great, thank you, Andrew. Well, I think the other questions there, which I think are more specific, and we'll do our best to answer those after the event directly. Namu is going to put a short survey link into the chat box, and so we'd be grateful if attendees could click onto that survey and respond. I'd like to thank Namu and her team for organising the event. She's made it extremely easy for me as a newbie, and particularly I'd like to thank Andrew for his excellent presentation. Made it very, very clear, very exciting. and for purely personal interest, I'm looking forward to learning more. I guess in this treatment, there's no magic bullet, isn't it? Is there in this treatment? This whole mixture of becoming fitter, of moving, of trying to get as much early stage supports as possible. And when you get to the point where you do need a replacement, that's a replacement is done once, and it lasts you for as long as you need it to last. So, and I guess as the population grows and as we live longer generally, then there'll be no shortage of candidates. So Andrew, thank you very much indeed for the presentation. Nabu, thank you. Thank you for everybody who joined the event as well. And I look forward to further events in the future. And have a good evening, everybody. Thank you.
Thank you.